Welcome, everyone. Thank you all for joining us, and for those of you that'll be watching us on YouTube, thank you for tuning in. My name is Nathaniel Van Kirk. I'm a clinical psychologist and the president of OCD Massachusetts, and this is our monthly virtual lecture series. And today, it's a pleasure to get to introduce Dr. Esra Guvenek, who is the medical director of the OCD Institute for Children and Adolescents at McLean Hospital, and is going to be with us today to talk a little bit about medication treatment for pediatric OCD. And give a little bit of the overview and also address some concerns that might come up, and then we'll have a little bit of a Q&A and talk about some common questions that might come up when it comes to medication, especially in children and adolescents. So, Esra, I'll hand it off to you.
Thank you, Nathaniel. Hi, everyone. I'm Esra Guvenek. So I'm going to talk about medications and how we approach the medication treatment for pediatric OCD. Sorry, 1 second. All right. Here we go. So just an overview of what we're going to cover today. We'll talk about how pediatric OCD can be different than adult OCD, what are our medication treatment as a first line, which is the SSRI, selective serotonin reuptake inhibitors. We'll talk about what happens when SSRIs are not enough. We'll talk about our approach to treatment resistance or treatment refractory cases, those patients who don't respond to first line treatment. And finally, we'll talk about how we balance benefits and side effects of the medications. So pediatric OCD, it has a prevalence of 1 to 2%, meaning 1 to 2% of the pediatric population can present with OCD symptoms. We see a bimodal age of onset, and what I mean by that is a good chunk of patients show up with symptoms before they hit puberty, and another peak, another big group of patients show up with the first symptoms, like during transition from adolescence to adulthood, early adulthood. So there's sort of bimodal, like 2 peaks as we look at the trajectory of the first symptom presentation. I'm saying this, but patients can come to treatment at any stages in their symptom presentation. And usually for medication treatment, it takes a long time to come and see a psychiatrist. Mean time from initial symptom into medication treatment, somewhere between like 7 to 8 years. So that's a long time. For what's different about pediatric OCD is that not all of them progress into adulthood. That's why we always think about treatment taper, treatment and also it's a kind of important concept to think about, the treatment doesn't mean that it's going to be lifelong or permanent. In children with OCD, some of the symptom difference, we tend to see more harm OCD, aggressive OCD, like what if I hurt someone kind of fears. And we tend to see more atypical rituals, such as blinking, like breathing, which we don't see that kind of stuff too much in the adult population. There is greater genetic loading, up to 12% of patients, kids with OCD have a first degree relative who also have OCD. Our approach to assessment is through white box, like Yale-Brown Obsessive Compulsive Scale, and there's a child version we use with children and adolescents, and it's sort of a different than adult version. Like we do this screening with both the kids and the parents, and kind of see how the kid sees themselves and their symptoms, and then how the parents see them. Then we rate this in terms of how much it impairs the functioning, how much the kid can resist, and how much time they spend on in obsessions and compulsions. There's a subgroup of OCD symptom specific to kids that's called PANDAS, and the talk is not this talk is not about PANDAS presentation, but I briefly want to mention that PANDAS is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection, and can be can be post-streptococcal infection or any infection, what we call PANS, and it's a very a specific form of OCD presentation. It's usually seen an abrupt onset of OCD, a lot of times along with tics, and some neuropsychiatric symptoms such as change in handwriting, bedwetting, more of a neuropsychiatric picture, and often seen as a reaction to the strep infection or some sort of infection. Right after the infection, that some kids can present with abrupt onset symptoms. And treatment approaches, treating the underlying infection, And there's some other like infection or post-infection specific treatments. But from an OCD perspective, we still treat OCD as OCD treatment. And it's sort of, we see this in a pre-pubertal kids. So usually it is like before puberty, and we don't see it in adolescents and young adults. Like onset of symptoms should be pre-pubertal. Moving on, I want to talk a little bit about diagnosis, what diagnosis we consider when we assess for OCD. You know, what I say comorbidities means like other disorders that can co-occur along with OCD, and differentials meaning what other diagnoses we should consider, you know, if the clinical picture looks like OCD but may not be OCD. For example, tic disorders are very common, you know, that we see a lot of tics in kids with OCD. Other anxiety disorders are very common, such as social anxiety, you know, specific phobias, separation anxiety, sometimes GAD, generalized anxiety. ADHD is common, or sometimes it's just the ADHD, sometimes ADHD-like symptoms, some form of executive difficulties. Mood disorders are common, and it could be a separate mood disorder. It could also be secondary to OCD, like for patients who have a long course of OCD that doesn't respond to typical treatment, or very impairing. They may develop depression because of their OCD, because it can be very hard to live with that kind of symptom burden. Autism spectrum is not that common, but they can co-occur. And it can be both like co-occurring ASD and OCD. And sometimes ASD itself can be misdiagnosed as OCD. Kids on the spectrum can present with some stereotypies and self-soothing repetitive behaviors. They can be misdiagnosed as OCD. The other differentials we think about, this is mostly for late teens and young adults. Psychosis spectrum illness, especially if OCD is presenting with some psychotic features, you know, a lot of, you know, firm beliefs, poor insight, meaning, you know, the patient may think that those worries are, you know, they're very enmeshed with those thoughts, and they cannot be challenged. And you know, it is not that common, but it can present in a form of OCD, and we can also see OCD with psychotic features, which may not be a psychotic disorder, but it can be a form of like OCD symptom presentation. But again, this is something we think about with OCD with poor insight, if mostly for late teens and young adults. And then it's also important to mention that kids with OCD often have poor insight, like they may not have a good understanding of their illness. It's pretty normal and pretty common, and that doesn't mean that there's a concern for it. Moving on, so let's jump into medication treatment for pediatric OCD. So first-line treatment is selective serotonin reuptake inhibitors, what we call SSRIs, medications like Prozac, Zoloft, Lexapro, Luvox. These are all in the class of SSRIs. And the evidence is very clear. SSRIs work, they're better than placebo, and they are safe, and they're the first line for OCD treatment. The way we define treatment response is based on how much reduction we see in the Cybox assessment. And if for a full response, we usually expect some symptom reduction above 35%. And for a partial response, we usually see a symptom reduction somewhere between 20 to 30%. And for patients who are still full responders of SSRIs, if the initial symptom burden is really high, they may still be highly symptomatic despite having a response to SSRI. So I want to mention that because it's important to notice, you know, the medication is, response to medication doesn't mean that having all your symptoms cleared. And then do we think about medication treatment? So some of our knowledge also comes from POT study. This is in the early 2000s. What they did was looking at different arms of treatment. One arm is, you know, CBT with medication, and they use sertraline for this trial. CBT with the SSRI arm. One of the treatment arms. The other treatment arm is medication only, just sertraline, and the other treatment arm was CBT. And what they found is that combination treatment works the best, which is better than CBT or medication alone. I mean, they all worked, but combination treatment worked the best. And when they looked at the remission rates, meaning, you know, how much the symptoms stay at bay when the treatment is tapered, what they found is that combination treatment brings much better remission rates compared to therapy, which was also better than medication arm. So I think the lesson learned from the study is that combination therapy tends to work more stronger because we're using all the tools we have to treat OCD. It's also like, you know, not every OCD needs to start with medication. We usually recommend starting with therapy alone for especially mild cases. They can respond to ERP, you know, CBT treatment with ERP, that's fine and may not need medication treatment if there's access to good ERP therapy. But for moderate to severe cases, it's very hard to engage in ERP without medications on board. And that's a big ask, I think, for patients to do. When the symptom burden is high, it's very, very hard to progress. It can be very demoralizing not to see progress on the hard work of ERP. So recommendations for moderate to severe cases for symptom presentations, it's important to kind of use a combination treatment for a good response. And then also kind of important to emphasize that when we say therapy, we mean CBT with ERP. It has to have an ERP component and not just cognitive reappraisal. Moving on. So how do we use SSRIs? What dose do we use? How long do we use? And how do kids respond to the treatment? So the medication work, but not for everyone and not fully. Half of the patients have some residual symptoms despite having a response, which kind of makes us to think about other strategies or augmentation, like adding another medication or doing something with the medication to make the medication work better. And maybe 1/3 of the patients don't respond to first-line treatment. One of the safest and best way to augment the treatment is increasing SSRI dose. There is very clear adult literature showing that higher doses of SSRIs works better for OCD, you know, which is different than depression or some of the anxiety treatments. OCD tends to respond better with the high dose SSRIs, which can be a little challenging with especially younger kids because they don't tolerate high doses well. You usually want to watch for activation, you know, restlessness, sometimes agitation or sleep problems. But if a kid is tolerating the dose increase, that's usually the first thing we consider, and you know, gently, slowly, but surely going up on the dose. And how long we treat is again, like more data from adult studies, but the recommendation is about a year after successful treatment. And important to, like, then it's time to taper, which is very reasonable to consider taper, especially for child OCD. Then it's time to taper, doing it slowly, gradually, at a time when the stress is low is much more successful. Usual recommendation is sort of somewhere between 20 to 25% dose reduction every other month or every 1 to 2 months. And the slower we go, more like safer taper will be. Moving on. So this is the kind of like different medications that can be used for OCD treatment. You know, fluoxetine, Prozac, sertraline is Zoloft, fluoxamine is Luvox. Those are the commonly used medication. We don't use paroxetine and Paxil kids because of the short half-life and side effect profile. And Stelopram, or more commonly we're using now Estelopram, which is the kind of improved version of Stelopram, is a newer, relatively newer, and now it is generic, so we can prescribe it. It doesn't cost as much. Mostly we use Estelopram. And the other medication on here, and I'll talk about it in a minute, is clomipramine, which is not an SSRI, but it's another good medication we consider for OCD. So my next slide is about what if SSRIs are not enough. I mean, we talked about 1/3 of kids may not respond to first treatment, or maybe half of them have residual symptoms that need some augmentation. So kind of moving into clomipramine, so it is a serotonin selective tricyclic antidepressant. So it's a different class of antidepressant medication. It's the first agent that was approved for OCD treatment. It's gold standard. You know, it's a good medicine, but because it's a TCA, it comes with a higher side effect burden. It can cause, more sedation, dry mouth, blurred vision, constipation, sometimes tremor. We need to get a baseline EKG just to make sure heart is okay. So it has a higher side effect burden. It might be a little harder to tolerate. So we usually consider clomipramine if patients tried 2 other SSRIs and didn't have good enough response. And not tried at the low dose. When I say try, like actual proper trial of 8 to 12 weeks on an adequate dose of SSRI. After 2 failed SSRI trials, then we usually recommend clomipramine trial. Clomipramine can also be used as an augmentation agent if an SSRI medication is working but partially working. Sometimes we can consider low dose clomipramine to make the SSRI work a little better. Our most common augmentation strategy, and augmentation meaning adding a second medication to make the first medication work better, so they kind of work synergically. The most common augmentation strategy and the most effective we have is using antipsychotic medications. Antipsychotics, like in the class of antipsychotic medications, they often work towards like a dopamine-based receptors in the brain. They block the usually D2 dopamine receptors, and they can be a good agent to consider if we don't have enough response to SSRIs. And 1/3 of patients who don't respond to SSRIs or partially respond to SSRIs, they have a very favorable response when antipsychotic medication is better. Again, most of our understanding comes from adult literature, but the medications that work the best for OCD are risperidone or risperidone, aripiprazole or Abilify, haloperidol, which is an older antipsychotic. And there's some evidence for olanzapine, Zyprexa, quetiapine, seroquel. They're not usually the first line for OCD treatment. And because like our decision usually comes from like side effect profile and tolerability, often we, I personally start with aripiprazole or Abilify, and if there's not enough response to aripiprazole, then we may consider risperidone because Abilify is a bit easier to tolerate. And the one other thing to consider when we talk about antipsychotic augmentation is patients with OCD and tics, comorbid tic disorder, they tend to respond really nicely to antipsychotic treatment. So for those patients, we decide to add on antipsychotic medication much sooner because their response is excellent, usually to antipsychotic augmentation. So that's one subcategory of OCD presentation, like we think about antipsychotic medications kind of sooner than later. There are other strategies we can consider. SNRIs like select serotonin norepinephrine reuptake inhibitors, medications like venlafaxine or Effexor or duloxetine or Cymbalta. Those are not the first line OCD treatment, and we usually consider them if there are other comorbid conditions. For example, I usually consider Effexor or venlafaxine if there's comorbid depression that's really hard to treat, or it doesn't respond to SSRIs, or duloxetine or Cymbalta for comorbid generalized anxiety disorder. Benzodiazepine, another class of medication, sometimes we see in treatment of anxiety and OCD. They are not OCD treatment, and we try to not use them as much as we can, especially with younger kids. It can have some paradoxical reactions. It can create more, disinhibition or anxiety or agitation in little ones. But sometimes for select patients, we like patients who are too anxious, to the point that they can't eat or they don't sleep or they can't go to school. Sometimes a very brief intervention, we may consider benzodiazepines, but again, it's not OCD treatment. It's more of a band-aid just to reduce the level of anxiety. And we're very mindful of not using benzodiazepine with ERPs because benzos can interfere with learning. And we try not to combine them with the ERP therapy. But there might be, situations where benzos might be indicated with due to, high anxiety symptom burden. A couple notes about invasive procedures. They're limited, almost non-application in pediatric OCD, such as neurosurgery or deep brain stimulation. There's some select evidence for adults in severe cases, but it's not applicable for kids. ECD, neither pediatric nor adults, there's no evidence for ECD for OCD treatment. There is some evidence for TMS. This is transmagnetic stimulation. TMS it's a non-invasive procedure and first approved for depression, and maybe considered for OCD, sort of more of upcoming literature on OCD, and maybe considered for select cases, especially if there's a comorbid depression. And there's some applications for adolescents. Moving on, so new agents or novel agents, some of the outside the box thinking for patients who don't respond to treatments that we've discussed so far. I'll briefly mention them. None of them are kind of game changer. There's nothing, significantly, and there's not enough evidence or significant impact that would change our practice. Some of them are targeting a different neurotransmitter in the brain, the glutamate, which is a major excitatory neurotransmitter in the brain. And some of the idea is sort of targeting towards learning. And it might be, we might have some treatments in the future within the glutamate receptor target, but unfortunately, none of these agents are necessarily like a game changer at this point. I'll briefly mention them. So ketamine is an anesthetic, usually using for anesthesia. There's some small adult studies with some limited response or mixed results, but it's not applicable to pediatrics at this point, given the invasive nature. Is cycloserine is another new agent. It's sort of exciting. The idea is sort of maybe it can it enhance learning in ERPs? There's some small adult trials with mixed results, but there might be more information about this in the upcoming years. Riluzone is another glutamate-based intervention. It's a treatment for ALS, amyotrophic lateral sclerosis. It's like a neurological condition. And there's some trials on OCD with some mixed results, but we don't use in pediatrics because the results are not impressive, and then the risk of liver toxicity and pancreatitis is there, so it's sort of too risky to try. NAC is an acetylcysteine. It's antioxidant. It's a pretty safe, mild agent. Usually in medical practice, it's used as an antidote for Tylenol poisoning. And there's some small randomized trials showing some improvement compared to placebo as an add-on strategy to SSRIs, but again, it's not that impressive. And then we usually consider it. There's some other indications for NAC, such as skin picking. So if there are a lot of comorbid conditions, we may consider, but again, it's not a very effective intervention. Namenda is another one. Memantine. It's an Alzheimer's treatment, and there is some studies with some response, and again, like very small and non-impressive. There are some upcoming pediatric studies actively recruiting, but nothing confirmatory at this point. But it has a mild side effect profile. It's very easy to tolerate, and it can be considered in select cases. Moving on, lamotrigine, lamictal, it's used usually as a mood stabilizer. Some small trials with limited effectiveness, and sometimes can be considered with a comorbid mood disorder. Celecoxib, it's a painkiller NSAIDs, and there's some adult studies, but nothing in peds, and not impressive. And then finally, Zofran or ondansetron is an anti-nausea medication. Again, something studied for OCD with kind of limited data. All right, moving on. So how do they approach the cases that hasn't responded to treatment or hasn't responded to, first or second line treatments, what we call treatment resistant or treatment refractory patients? So what is our, how do we assess these cases and what can we do about them? I think it's important to kind of start with defining what treatment refractory means. From a treatment standpoint and medication standpoint, the way we define treatment refractory as patients who failed 2 SSRI trials or 1 SSRI and a clomipramide trial. And in addition to medication trials, they haven't responded to a good CBT with ERP trial. So it's not either or, it's both two good medication trial and CBT with ERP treatment. And one of the first questions I ask when I'm assessing a patient with who hasn't responded to treatment, sometimes they may be referred to our residential program. One of the first questions we ask is the diagnosis correct? So are we seeing OCD? Because sometimes autism spectrum disorders with a lot of restrictive interest, perseverative, repetitive behaviors can be misdiagnosed as OCD. Sometimes ruminations with depression, like depression can come with a lot of anxious ruminations, repeated anxious thoughts due to depression. It can be misdiagnosed as OCD. Sometimes emerging psychosis can be misdiagnosed as OCD. So that's usually the first question, I ask, okay, what is the diagnosis and is the diagnosis correct? The second, and if the diagnosis is correct, it's OCD, then the second question we ask is, are the first-line treatment optimally provided? From a SSRI or clonazepam medication trial, it's very important for us to differentiate failed treatment versus treatment intolerance. What I mean by treatment intolerance is that patients who are very sensitive to side effects, and they may not be able to reach a meaningful dose of a medication. For example, someone who tried, multiple SSRIs, but all the doses are very mild and very small and very brief trials, like fluoxetine Prozac 5 milligram or sertraline 25 milligram, and tried and felt discomfort or felt anxious on it, and they couldn't have a meaningful trial. So that doesn't count as a medication trial. And for those patients, our work is towards treatment tolerance. Like we work with the patient and families to increase treatment tolerability. And then for a good SSRI trial, we would like to reach a total of 12 weeks of treatment and at least 8 weeks at a good maximal tolerated dose. And anything shorter than that, we usually don't count as the full trial. The other issues that comes up is medication compliance. We always assume that patients are compliant with medications, and reality may not be the case. We always assess for what kind of therapy patient is receiving and whether the CBT is ERP based, because it's really crucial to do exposures and not just cognitive component of therapy, but rather the action ERP component, because that's what brings the main change in OCD treatment. And there are other things we assess. We assess for comorbidities. If there is untreated depression, it can interfere with patients' motivation and ability to engage in treatment. If there's ADHD that really interferes with learning in ERPs, that we may need to treat ADHD for patient to have good response to ERP treatment. We also look at level of insight. Patients who have better understanding of their illness are going to be more likely to be motivated to engage in treatment. We always look at family accommodations. Patients can learn how to push back on OCD, and we really need families to continue that kind of work at home. And if the kid does a lot of work in therapist's office but goes home and family is more accommodating to OCD, then it may not really generalize or progress into good response. And overall, we want for folks who struggle with treatment engagement, we really try to use motivational interviewing and some other techniques to increase treatment engagement and compliance. And finally, I want to briefly talk about how we think about medication risk and benefits. How do we understand, side effects, and how do we make these decisions? And usually with these medication decisions, it is a mutual decision. It is not, psychiatrists telling patients and families, this is what you're going to take. It's usually a discussion about options, benefits, side effect, and mutual decision, and the team effort in monitoring response and side effects. So it's really important to kind of conceptualize medication treatment as like a team effort rather than, psychiatrists telling, patients to, take this medication or that medication. the goal in medication treatment is sort of reaching a good therapeutic window with good clinical response, adequate clinical response, and acceptable level of side effects. So I think it's important to sort of think about side effect as an acceptable level, because we're not targeting no side effects. Like some side effects can be seen and can be easily tolerated. They may be transient, they can be managed with some other medications. It's really important to sort of come to treatment with that mindset that you may have side effects. Some of them can be serious that may need to be stopped treatment, but some of them can be mild and transient, and it's okay to push back. It's okay to tolerate that kind of discomfort, and it will eventually improve. And that's sort of like working towards treatment tolerability, treatment tolerance, which will increase the chances of a successful trial. The other things we consider is, practicing evidence-based treatment, recommending medications that have evidence and that works for OCD, less experimental trials, because the more trial and errors and not getting response creates more disappointment. So the more evidence-based practice, more likely that we will see a response. I always have a conversation about what medications can and cannot do, and what is the role of medication in OCD treatment. And the way we see it is more like one of the tools in the toolbox. And the role of medication is to tune down the intensity of symptoms so patients can engage in exposure therapy. Because we know when the symptoms are so high, it can be very, very hard to do meaningful ERP. And we would like medication to work synergically with exposure therapy. There are many concerns or many fears come up when we think about medication, starting a medication treatment. OCD can also very much interfere with medication treatment. Some patients may feel that medications are very strong and they will change their whole personality, which is not the case. I always say medication is not stronger than who you are. There's some kids are very worried about starting a medication means, they're going to stay on medication forever, which then I sort of try to educate them on, no, it can be very short term. Let's see how it works and if you benefit from it, and let's think about the timeline, like a trial period, and you may be able to come off of medication. It's not a forever thing, especially in pediatric OCD. Some patients may be afraid that if they take a medication, that means they have a severe case, or they're hopeless, or they'll never get better. As if taking a medication means they are kind of beyond help, and we kind of address those false beliefs and educate them about normalizing about receiving treatment, and medication being just one of the treatment tools that you could use. Some kids are worried about impact of medication in the brain, as if medication can make this permanent damage or some sort of structural change. So we talk about that not being the case. And then I try to normalize, OCD has an impact on your brain, so medication will be there to kind of help you with that. I think sometimes when we talk about side effects, we kind of forget to talk about the risk of not treating. And I always want to bring that discussion into, okay, there could be risk and side effects of taking the medication, but there are also risk of not getting optimal treatment for your condition. So what is the impact of having a high OCD symptom burden to your brain? What is the impact of dealing with this so intensely every day, all the time in your life? And this might be a higher risk than the risk of having a side effect from the medication. And the final, I think the one side effect I want to talk about, which can come up a lot and a lot of fears around this, is the black box warning on SSRIs. So the black box warning, if you kind of look at the Prozac or any of the SSRIs, it sort of has a warning that SSRIs can increase suicidal thinking in children and adolescents and young adults. And this is after a very detailed pooled data, looking at the suicidal thoughts and behaviors. And what they found in the big pooled data is that the treatment arm is reports slightly more suicidal ideation, but not attempts. There are no attempts in that data. compared to placebo. And that sort of obviously, I mean, that is a concern, like understandably, we need to monitor for that, even though it's a very small group of patients. If they're feeling more like suicidal while on the medication, that's something that needs to be monitored. And that's usually the recommendation. Recommendation is not to withhold treatment, but rather monitor for this. And it's a rare side effect. It doesn't happen often. It's a very small group of patients have this kind of response or reaction to the medication. And there's a lot of, ideas or speculations or thoughts about what might that be. For some patients, when we treat their depression, they may feel more activated or more willing to talk about the suicidality. I mean, I think it's very complex. So anyway, so FDA ended up putting that warning in 2004 to bring awareness into this issue and making sure that, we monitor for this. And unfortunately, that led into a lot of fear about, using this very safe and very effective group of medication. And the care has shifted from primary care into more specialists, like pediatricians or family practitioners became more concerned about prescribing SSRIs, which kind of led to a significant decline in SSRI prescribing, which kind of highly correlated with increased depression and suicidality in children and adolescents. So, which is very unfortunate, and because it seems like the fear about the medication led to underutilization and untreated, depression in children and adolescents. And so the takeaway point from this is that, even though a very small group of kids may have this kind of side effect, the majority of kids do benefit from this class of medication, and this fear of having this very rare side effect should not withhold treatment, because when we withhold treatment, the results are not really optimal. I think I'm going to pause here, but this is sort of a summary of how we approach medications, how do we treat OCD and pediatric OCD, and what are the questions and concerns can come up when we have medication conversations. Okay.
Great. Thank you so much, Esra, for a wonderful overview. And, I really like that statement that you said in terms of the way you respond to the concern about medication in terms of changing like who you are, and the idea that medication isn't stronger than you. I think that's a really nice way to frame it.